Start so.
Okay. Very good evening to all the doctors who have joined the meeting. So today's meeting, like a Nubeca clinical conversation update, a prostate cancer update. So we have three speakers who will be talking on like Arasen's trial, Aronot, and a case presentation. So without much wasting the time, I would like to invite Dr. Arun Chandrasekharan, uh, consultant medical oncologist, Aster MIMS, Calicut. Sir, over to you, sir.
Yeah, hi. Thank you, Vinodji, and thank you to Bayer for conducting this CME. So today we're going to focus on darolutamide. So we have two eminence oncologists, Dr. Rakesh from Amrita Institute and Dr. Santosh from Hyderabad Star Hospital with us today. So today we'll be discussing the data that is there about darolutamide in prostate cancer. So as we know, darolutamide is a molecule that is been there in India for some time with two major indications. One is through the Arescens and the RMS trial in non-metastatic CRPC as well as or metastatic hormone-sensitive prostate cancer. So hopefully we'll be, able to educate more people regarding the benefits of the drug, its reduced toxicity, and where it stands in the treatment of prostate cancer today. So without further ado, I'd like to introduce our first speaker who would be speaking about the usage in metastatic hormone prostate cancer with the topic reaching new heights in metastatic hormone sensitive prostate cancer care. So we have Dr. Rakesh MP, professor in medical oncology in Amrita Institute of Medical Science in Kochi. Over to you, Dr. Rakesh.
Evening, Arunji and thank you for the opportunity. One correction, not professor yet, still associate professor. So
you get there.
Yeah, so thank you for thank you, Bayer, for the opportunity to talk about darolutamide and its and also the current trends in management of prostate cancer. We have come a long way from just ADT to the current Arescens and improvement in certain HSPC, thereby prolonging the progression to a CRPC and thereby prolonging the overall survival. So without much delay, I'll start off with my slide. Can I share my slides? Is my slide visible?
Yeah, it's visible.
Yeah. Yeah, so this reaching new heights in HSPC care. So all these slides have been brought up by Bayer, and there's my slides. And again, as a busy Monday, all of us I think all of us just rushed from OPD. So I've just briefly brushed through I could only brush through the slides just a half an hour back. So pardon me if I've committed any mistakes. So basically, we all know that once CRPC sets in, there is definitely a drop in survival. So our aim is to hit hard before it becomes CRPC, and when that right point is either at locally advanced stage or when at the point of early biochemical recurrence or when a newly diagnosed HSPC state. So that you can delay the occurrence of CRPC and thereby improve the overall outcome of the disease. So we all know that how this is an extract from from Stampede trial, which established the role of docetaxel and further ARP docetaxel, and we know that how inferior the survival was for the control arm, that is the ADT alone arm, because at the end of 1 year, 50% of the events have already taken place, or the overall survival at 36 or at 3.5 years, 50% of them have already been died. So that is a poor that was a poor outcome or survival, especially in the control arm and the Stampede trial. So now we can do much better. Now the control arms are much better, and also the trial outcomes are also much better because we have better comparator arms nowadays. So this slide shows the so the role of prostatic RT in MHSPC, that is, there is the role of RT. Says that there is a role of local RT, especially in low volume diseases or in bone mets that less than 4, and there is no definite role or improvement in FFS or OS if the high volume disease or the bone mets more than 4. So we have come a long way from 2013, the first JTAC 15 trial, to 2022 with the approval of multiple multiple molecules from ARPIs and darolutamide and palitomide and enzalutamide. And currently we stand with Essence, which was published in 2022, and we'll be discussing about Essence trial. Before that, we'll just quickly go through one slide per trial. First start off with Charter trial, the role of docetaxel in HSPC. Definitely there is an improvement in survival in high volume disease, that is high volume, that is 4 or more mets and bone mets, with 1 being an extra spinal mets and visceral metastasis. They did show an improved survival with docetaxel, and however this improved survival was confined to high volume disease, and the role of chemotherapy in low volume disease was still questionable. Questionable, as seen in Chartered. And moving to Latitude, which established the role of ARPIs or abiraterone in high-risk HSPC. Again, we can see that there is a definite improvement in overall survival on addition of abiraterone to ADT, and is the first to show that the hormone therapy can be effective. However, as I said before, the control arm was very poor. You can see that the PSA specific progression was around 33 versus 7.4, which is actually how inferior the control arm was, which exaggerates the effect of abiraterone in Latitude. However, this established the role of abiraterone, which is currently our go-to molecule till the Essence, and majority of the patients are still we start abiraterone because of the easy accessibility and a more tolerable safety profile. Even if I say tolerable safety profile, even if we say the steroid accompanying steroid is only fine, there is still a significant percentage of patients who suffer from metabolic disorders, metabolic derangements, heterotoxicity, and hypertension. Hypertension is and electrolyte abnormalities like hyperkalemia is something that very common. It's not uncommon basically, or in fact commonly we come across, especially when we deal with an elderly or about 70-75 years of age patient. So we need to be careful and before prescribing abiraterone, especially in elderly and with other comorbidities. Titan, slide on Titan, which established the role of palitomide and with ADT versus with placebo in MHSPC, and again this established its role in improving the PFS as well as OS. And especially in the low volume disease. Here, something also the benefit was slightly more in the low volume and then the high volume disease. And Enzamet, as we all know, was the role of enzalutamide versus the other non-steroidal agents like bacalotamide and enzalutamide. And they found that there is a definite improvement in overall survival, that is up to 0.67 as a ratio with a p-value of 0.02. And again, the role of more confined to low volume more than the high volume. So with this differential effect, like certain molecules do well in low volumes and don't do low volume, only in high volume. We have current theme is to combine therapies so that there is an improvement in overall survival. The first one of this lot is a phase 1 study design, which included the metastatic HSPC first line, de novo M1, and again stratified on the basis of high volume and low volume. High volume being defined as the Charter definition itself, that is presence of visceral metastasis or 4 or more bone lesions with 1 beyond the vertespinal, the axial skeleton, and the performance status were They include only patients with good performance status. And this were into abiraterone group, abiraterone with radiotherapy, abiraterone with additive with docetaxel, and the pooled abiraterone also had radiotherapy as well. So this showed a definite improvement in survival. As we all know, there's a dramatic improvement in survival, especially in the high volume disease. However, this improvement in survival is not reflected in the low volume disease, or we say that, or what we say is we usually reserve this peace protocol, that is ADT with triple therapy, usually if it is a well-fit high volume gentleman and an elderly patient, low volume disease may not use may not gain a benefit from adding abiraterone to docetaxel versus docetaxel alone. And with this in mind, there comes the Erasmus study design. That is, again, it is a unlike piece one. This is a global double-blinded study. There was an open label study where, again, first line HSPC with a well-preserved performance status, and patients were candidates were fit and eligible for docetaxel. They were stratified on the basis of on the sites of methods, bone-only mets, lymph node-only mets, bone-only mets, and visceral metastasis. And they were randomized on 1:1 to docetaxel plus daratumumab with ADT versus docetaxel plus ADT only. And again, endpoints here, the primary endpoint was OS, unlike PEACE, where it was a failure-free survival. And secondary endpoint was multiple secondary endpoints. So very important secondary endpoints like time to cessation of CRPC, time to pain progression, symptomatic skeletal event-free survival, and time to first symptomatic. These are all very important secondary endpoints because there are certain things that we come across in almost all MCS, PCPC when they become CRPC, because with new molecules coming in, survival has been improving. And one good thing is almost 90% of them could tolerate all 6 cycles of docetaxel in the trial. So when compared to PEACE one, which is an open study, the primary endpoint was not OS, the failure-free survival. This is more, from a design point of view, the essence was more stronger than the PEACE one trial. So the results, definitely there is an improvement in overall survival with a hazard ratio of 0.68, or you can have a 32% reduction in risk of death when you start off with darolutamide with with chemo, with docetaxel, with ADT. And this benefit is seen across in all groups, both high risk and low risk group. Again, a point to be noted that in PEACE one, the benefit on addition of abiraterone to docetaxel was confined to high risk group and low risk. But here there is a benefit. The benefit is seen across both high risk as well as low risk group. And with risk and more than numbers, I always rely upon hazard ratios because that magnifies establish the extent of benefit. Like you have a hazard ratio of 0.7, or there is a 29% reduction in death in high risk patient, and almost a 38% reduction in low risk patient as well, of death in low risk patient as well. So what and similarly, this effect is seen in secondary endpoints as well. That is, you can see in time to CRPC has been delayed and with a very strong p-value of 0.001 and hazard ratio of 0.36, and time to pain progression, that is symptomatic, the symptomatic skeletal met is also delayed, and the time to first subsequent antineoplastic therapy, that is time to next line, also be significantly delayed by prolonging relapse or progression-free survival. And this is seen in almost all subgroups. And moving on to the PSA response and outcome, we can see that at 24 undetectable PSA, that is undetectable PSA is less than 0.2 in 0.2 nanogram per deciliter. So in 24, by end of 24 weeks, for almost 50% attained undetectable PSA. By end of 36, almost 60%, almost 57%, and at any point of time, those are almost a doubling of 25 and 65% of them were in undetectable PSA range. And undetectable PSA range reflects an improvement in overall survival as well as an improvement in PSA progression as seen in these two graphs. Because undetectable PSA at 36 weeks, we can see that there is the median is not reached. Even though here also the median not reached, there is a definite improvement in there's a definite difference, or there is almost a 67 or 77% reduction or delay in PSA progression when on addition of delay to the rise in PSA on addition of darolutamide to them. Similarly, this reflects in the overall survival as well, where the indetectable PSA level, the median at 36 weeks, the median was 33, where here it is not still reached at 36 weeks. So there is an improvement in overall survival probability as well on addition of darolutamide. Similarly, similar outcome is seen in overall in high volume HSPC as well. I can see that at any point, as seen in the previous graph, it was 65 and 20, 67 and 25. It's almost same here as well. It was 60 versus 25. At any point, 60% of them had an undetectable PSA level, and undetectable PFL that is less than 2 nanogram per deciliter, 0.2, it's not 2.2. Would reflect an improvement in overall survival and also a time to PSA progression. And you can see some magnification hazard ratio of 0.2 and 0.3 here, which is usually rare in solid tumors. Talking about hazard ratios in solid tumors, you can see in low volume HSPC, you can see that time to PSA progression, the hazard is 0.09, which is almost all unheard of. And unheard of, I can see that the darolutamide at 36 months, the PSA progression is 33 at 33 months with the placebo, where it has not reached in darolutamide and similarly the OS, both of them have not reached. The median has not reached because, again, low volume disease by default they have a very good survival even in the control arm. But however, there's a 64%, 66% reduction in death rate, even in low volume HSPC on addition of darolutamide to docetaxel. So things to consider before prescribing or before starting triplet, whether the patient be able to tolerate or accept docetaxel is the most important factor. And whether it is high volume or low volume, we have seen that the PIS1 regime the effect is confined to high volume, and low volume we don't usually prefer PIS1. Whereas in Erasens, we can see the effect is seen equally in, or in fact more in low volume. Effect is there in both low volume as well as high volume. And higher the volume, there's always a higher chance for likelihood of hormone insensitive clones. So you have to hit hard, and longer the survival, you hit them hard early, and post ARP, we all know that the role of docetaxel or the role of the effect of Rockless is much less and it is less when compared to docetaxel when it is used upfront. So comparing these two trials at present, where do you place Erasens? I would say I would prefer Erasens, especially in a young, fit, high volume or low volume prostatic cancer who can access or easily afford darolutamide. And because its effect is even more pronounced in low volume as well. And also from a statistical point of, from a trial design point of view, it is more an open label design, and the primary endpoint is OS, and unlike the PIS1. And also the drug by itself, darolutamide, that's got less CNS penetration, less fatigue, less CNS side effects, unlike other other NSAIDs. So with this, if the patient accessibility has been sorted, I would still prefer Erasens here if for a patient of both upfront, both HSPC, both high volume as well as low volume. So that was my last slide, and thank you organizers for inviting me or giving me a chance to talk about this molecule and this trial. Over to you, RNG.
Yeah, thank you, Dr. Rakesh, for that comprehensive review of the data in metastatic hormone-sensitive prostate cancer. So I think we'll have a small discussion after the presentations where we'll just see what we do in our practice per se. So thank you once again for that, Dr. Rakesh. And moving on, the next presentation will be by me, and we'll be discussing the data on the ARANOTE trial. So if I can share my slides. So, slaps this. Okay. So I hope my slides are visible. So thank you again for joining in. Now, today we are going to be discussing the data from the ARANOTE trial, which is basically usage of darolutamide without chemotherapy with ADT in the first-line hormone-sensitive setting. So the slides have been provided by Bayer, and I've not made many modifications at all. And to start off with, we know that the standard of care in hormone-sensitive prostate cancer has changed. And if you look at all solid tumors, probably prostate cancer is the one which the maximum improvement in overall survival has been seen over, the last 20 years or so. So it started with the Chartered trial where chemo was added to ADT. And in the first line setting, then you had the Stampede trial confirming the findings in the Chartered. And the Chartered gave you what is high volume versus low volume disease. Then you had Latitude, where Ebritron joined in with ADT. Again, Stampede, with its multiple arms, had multiple ongoing, patients in various treatment sections, some with Abretron, some with docetaxel, some with radiation. And in the 2020s, enzalutamide, apalutamide all entered into the game as well. Enzamet also gave a triplet therapy, but unfortunately, the triplet therapy with enzalutamide did not show a benefit. So a triplet with enza is currently not standard. But then what became standard started off with the Peace 1 trial, which is Abretron with ADT and docetaxel, and which is most commonly used as a triplet therapy in first line today. And also the Erescence data came out in 22, which Dr. Rakesh has mentioned in depth and in detail, where darolutamide plus ADT plus docetaxel could also be used as a triplet. So we have two triplets currently approved in the first line setting. One, the backbone is Abretron, the other one is darolutamide. In 2024, darolutamide with its ARANOTE came in the first line setting, which we'll be discussing, and ARASEC is the second line setting of darolutamide. So in patients who have multiple comorbidities, who are taking multiple other drugs, you really need a molecule which can be tolerated without much toxicity. And this is where darolutamide comes into being. You have docetaxel approved in the first line, but there are, let's say, a subset of patients who develop a lot of toxicities who may not tolerate docetaxel. Additionally, you have low volume disease patients where docetaxel combinations may not be that effective. So it's in these kind of patients where darolutamide was envisioned to make a significant impact. And what we're going to discuss is the ARANOTE phase 3 trial, where you took this drug and combined it with ADT in the first line patient. So as of now, this trial published its data. It had included a significant number of patients from India. I think around 61 patients, which we'll discuss later, came from India, from across institutes like AIMS and in Kerala as well. And with this, the background of the ARANOTE states that you have darolutamide, means you have the Erescence data, which is the triplet therapy, which is the gold standard. And we wanted to see whether darolutamide by itself with ADT, whether it could improve the outcomes in patients without chemotherapy. So this was a randomized double-blind placebo-controlled phase 3 trial conducted in multiple countries. And they took patients with metastatic hormone-sensitive prostate cancer and stratified them into visceral mets present or absent and whether they had prior local therapy. Patients in the experimental arm received darolutamide 600 milligram twice daily with ADT in a 2:1 ratio. The control arm was just ADT. And the primary endpoint was radiographic progression-free survival, and we had a whole lot of different secondary endpoints as well. And after the initial analysis, the patients could, continue darolutamide as open label, and crossover was allowed in the control arm, and patients could receive darolutamide after that. Secondary endpoints also included the overall survival and safety. So there was a median follow-up of roughly 25 months in the whole study. If you look at the baseline characteristics, this gives you a snapshot of how our patients present inside India as well as throughout the world, a median age of 70 years. This trial had 32% patients who were Asian, which was quite significant. And most of them had a Gleason score of more than 8. So this was an aggressive disease and a median PSA of around 20. Upfront metastases were seen in around 70%, 22% were metachronous metastasis, and a high volume of disease was seen in 70% versus 30% with low volume disease. So this is as per the charted criteria, which means that these patients either had visceral mets or had 4 or more bone lesions with one outside the axial skeletal system. Visceral mets were seen in around 12, which is a little lesser. Majority did not have visceral mets, and prior local therapy was given in around 20% of the patients. So as you can see, the Aeronaut trial included multiple countries, including Africa, North America, Asia, Australia, whereas most of the other trials, like the Vision trial, was only among the Caucasian population. The COU trial was again in the Western world. The Embark trial had a few patients from South America. So if you look, all in all, the Aeronaut was the only truly global trial, which included the high middle income and low middle income countries as well. In India, we contributed around 13% of the patients, and a total of around 61 patients were represented in this trial. So this was the primary endpoint, which was the radiographic progression-free survival, and that was significantly improved. And the control with the use of darolutamide plus ADT, the hazard ratio was 0.54, which means a 46% reduction in the risk of death. At 2 years, 70% of the patients were, radiologically progression-free, whereas around 50% only were progression-free in the control arm. If you look at the benefit of this PFS across multiple subgroups, all patients benefited from it, including older patients, high PSAs, low Gleasons, high Gleasons, disease volume also, high volume and low volume, both of them benefited from darolutamide. All types of, all races of patients as well. Even patients with visceral mets had some benefit. So overall, all subgroups were benefited from this therapy. Now, if you look at the secondary endpoints, the overall survival data was not mature. The hazard ratio is 0.81 with the confidence interval crossing unity, but we have to wait for more mature data. Patients will be followed up. The time to metastatic castrate resistance was much improved with the use of darolutamide. Time to pre-SA progression was better. Time to subsequent initiation of anti-cancer therapy also was better, and pain progression as well. So all in all, these patients did benefit in all secondary endpoints as well. These are the charts showing the degree of benefit. As you can see, wide separation of the curves with healthy hazard ratios of 0.4 with time to castrate resistance. And we know that the maximum time that you delay to castrate resistance is better for the patient. The time to pain progression was also better. So patients are, living without pain much longer when you use darolutamide plus ADT versus placebo plus ADT. And this is very significant for patients' quality of life as well. Darolutamide also achieved deep and durable PSA responses. By undetectable PSA, we mean a level of less than 0.2, and 62% of the patients achieved this at any time. Only less than 20% in the control arm could achieve this. The time to PSA progression, as we discussed earlier, was also quite significant. So we have patients who keep following up the PSA, and this is quite important for patients because they're happy when the PSA is on the lower side, and it remains that way for longer when you combine this darolutamide with ADT. More patients achieved this undetectable PSA in the patients who have received darolutamide, and almost 44% at the end of 24 weeks, which is roughly 6 months, could achieve this undetectable PSA, whereas in the control arm, only 10% achieved this target. And over time, this percentage went up slowly, probably around 3 to 4% every 3 months or so. And at 1 year, roughly more than 50% patients achieved this undetectable PSA. Now, if you compare high volume and low volume, this benefit was there across the board, and darolutamide was effective in both these populations in reducing the PSA level as well. If you look at subsequent life-prolonging anti-cancer therapy, you can see that around 30% patients in the experimental arm received subsequent life-prolonging systemic therapy versus 42% in the control arm. Most of the next therapy received was docetaxel, as expected, as these patients were chemotherapy naive, but majority could not receive chemotherapy as well because of the worsening of clinical condition or such. They also received in various percentages abiraterone, enzalutamide, apalutamide, cabazitaxel, radium, and some patients also received olaparib, which tells you that in metastatic castrate-resistant prostate cancer, definitely you need to look at your BRCA1, BRCA2. BRCA2 is more common, and you also need to look at MSI as well. Now there's new data that you need to test your BRCA or your HRR mutations upfront because you have the new TELAPRO-3 trials, which tell you that using this combination upfront probably will give you better results. If you look at the treatment emergent adverse events, these were pretty similar, and this is where I feel that darolutamide has made a significant impact. Most trials, when you add a new drug or the experimental drug, you see an increase in adverse events. But here, the grade 3 adverse events were similar between placebo plus ADT and darolutamide and ADT. Death, which was a grade 5 adverse events, was seen equally, actually slightly more in the control arm. The experimental arm had around 5% death. Serious adverse events were seen in 23% of the population. Now, these side effects are almost similar in spite of patients being on darolutamide longer. So patients were on darolutamide for almost 2 years versus 17.3 months in the placebo arm. So this drug overall is very safe. And if you look at discontinuation, more patients discontinued placebo, almost 9% versus only 6% of darolutamide. So this slide, I feel, is the most important. If you have a patient who has significant toxicities or, who has significant comorbidities or on polypharmacy, who have fatigue, all of these patients, it is the best drug to use in this situation because you're not going to increase toxicity. So what are the toxicities which you may encounter? You can have anemia, arthralgia, UTI, back pain, some transaminitis. So all of them probably less than 20% chances, most of them less than 10%, and all of them mostly associated with the ADT as well. Probably fatigue is one of the common side effects that we associate with androgen receptor pathway inhibitors, but here it was hardly 5.6%. And if you see, fatigue was actually more common in placebo, 8% versus 5% with darolutamide. So very well tolerated drug. So this graph tells you the average, toxicities factored over 100 patient years, which basically means that, as I said before, more patients were on darolutamide compared to placebo. So you have higher chance of longer duration probability of getting side effects. Whereas patients on placebo stopped early, so probably they did not have time to develop side effects. So even if you balance these things out, you can see that actually, on an average, darolutamide has less toxic than the placebo. So if you see hypertension, which is 5.5 versus 6.7, and so on. So again, all these slides reiterate the fact that this drug is pretty safe and can be used in patients with significant comorbidities. Now, another important factor that most patients value is the quality of life. And in the quality of life also, the FACT score, which is the functional assessment of cancer therapy in prostate, the deterioration of the quality of life was delayed by 5.1 months when you use darolutamide. And this is one of the endpoints which is not commonly reported in many trials. And it's the first and only androgen receptor inhibitor as of now to show significant delays in reducing pain and significant delay in any worsening of the quality of life. So the charts are there with a healthy hazard ratio of 0.76. So looking at the subdivisions of the quality of life and the functional capacity, you have social, functional, and urinary symptom domains. And all of them, if you can see, is significance is improved in this forest plot. You have a significant difference from the line of the unity. Social family well-being is better, functional well-being is better, prostate cancer, the worry about prostate cancer is better. Urinary symptoms are also better. So the drug does outperform placebo in all these factors as well. So to conclude, what we can take home is that this combination of darolutamide plus ADT improved the radiographic progression-free survival. Overall survival data is not mature, so currently it's not significant. All patients, regardless of high volume or low volume, benefited. All patients had a deep PSA response, and importantly, darolutamide reduced the time to pain progression, improved the quality of life, and had lesser toxicity than placebo, and was very well tolerated with very low discontinuation rates. So it is a very good drug. And as of now, if you have a patient who cannot tolerate docetaxel, darolutamide plus ADT would be the safest option among all the androgen receptor pathway inhibitors or abiraterone for that matter. The only issues with the trial was that the ADT, the control arm was only ADT plus placebo. So this issue was raised in commentary in the ASCO publication, where this trial started recruiting in 2021 and 22, where the control arm could be considered suboptimal. But the authors replied that, in most of the places where they conducted the trial, they included low middle income countries. So probably they could not, have full access to, the other molecules to combine with ADT. So they wanted to maintain uniformity. And so that's why this this control arm was used. What data would have been better would have been darolutamide plus ADT versus any other androgen receptor pathway inhibitor plus ADT as per the Latitude trial, or even versus chemotherapy. And the benefit of quality of life and benefit of reduced toxicity is definitely there, and that could have been the primary endpoints, but that's my thoughts on reading the trial. So in practice, would I use this for everyone? Probably not. Triplet therapy would supersede this, but the Arescence data is there to utilize darolutamide. Would I use this in a patient with low volume disease who has significant comorbidities? Yes, I think it's that situation where definitely this would make an impact. So thank you for your patient listening, and we'll be discussing more in our session later. Now I'd like to,
Just a small comment.
yes,
Thing, and it's ironical because in my session, I projected a slide saying the inferiority of the controller, and I don't know,
yes,
they use the same controller. That is the only
correct.
thing, yeah.
So
So,
same company is batting both sides for both teams. So yeah, I remember you said that. So this part also, yeah, that's the contention. So probably let's see. As I said, it's not for everyone, but yeah, there is a population where we should be using it. So moving on to the next talk, we have Dr. Santosh Kumar from Hyderabad, who would be discussing a case and the utilization of darolutamide in his experience. So over to you, Dr. Santosh. Has Dr. Santosh joined the meeting? Oh yeah,
Hello,
he's
sir.
in.
How are you?
Oh yeah, hi, Dr. Santosh. Hope you're well. Still in OPD. Okay, so Hyderabad is very busy.
All
Okay.
this is the traffic. I work across two centers. Traveling from
Okay.
one center to other center takes a lot of time, actually. That is the main thing.
Oh, okay,
So,
okay.
actually, I'll discuss two of interesting cases in the spectrum that we are discussing. So, I'll share my screen and I'll start presenting. One second. I thought of using some AI elements in part of presenting the Zoom. So this is how the AI version of me looks. So I'll directly jump onto the case. We have a 76-year-old male presented with hematuria. So that was his initial presentation. Uh, at part of the time we have evaluated, he was found to have high lesions, metastatic castration, sensitive prostate cancer with a very high PSA, 36,500. This is the highest that I have ever seen. So I might request inputs from the esteemed colleagues if they have seen higher values in range of this. He was frail. He has hypertension, coronary artery disease with its own medication, and hyperlipidemia. So this is his exact scenario. What I do in a prostate cancer is especially to evaluate comprehensively, we to see if there are any HRR profile mutations and all. We have done the NGS upfront, so this is what I do routinely. In the NGS, we have found few alterations in the form of KDM6A, ASXL2, and MLH1. This is what we have seen in this scenario. This KDM6A, A6L2 all implies little bit aggressive biology. That is, these cases tend to go aggressively. This is what these mutations tell us. So to visualize the case, I cannot bring the patient in front of you. I used AI to depict what exactly is the condition of the patient. He's frail, as you are seeing in the picture, with comorbidities of coronary artery disease, hypertension, hyperlipidemia, and frailty. So with the PSA sky high of 36,500 and having a high volume, high risk, and also high grade lesion. So always we have to have the balance of the difference between the treatment intensity and how aggressively we are going. We should individualize the therapy, and at the same time, it should be patient guided. patient-centric and evidence-guided. So this is sometimes a complex scenario where we have data at one set and we have a completely different this one. So this is what I term as precision oncology. We need to have a multidisciplinary tumor decision making. So he has risk of fall. He has already polypharmacy. He is a highly educative retired personnel. He was very clear, sir, whatever it is, I don't want to suffer with the medication. You do what do you want? Benefit, but I don't want side effects. And he was having hematuria, a lot of bone mets, and he need very early response. We are dealing with a high volume disease, and he's not fit for chemotherapy, and there are no HRR mutation. So it's a frailty and a PS2. Here, one side we have a very high volume of disease, and at the other extreme we have a patient who is not fit for aggressive therapy. So we have to balance in this scenario. The challenges I encountered is the frailty, the elderly, the performance too, not at all fit for chemotherapy, very high volume of disease, need early response to control hematuria. We also contemplated of giving radiation also. There were no HRR mutation. He was already on polypharmacy, risk of fall, and most important, he doesn't want any side effects. So with this thing, we have started relugolix with darolutamide. He had very good general improvement and he's able to walk initially with stick and later he's able to walk with support in 1 month. And with 36,500, we have very good response in the form of 10.8, 0.47 and less than 0.2. So this is what we have discussed in the previous two talks by Dr. Arun sir and all, where at 6 months landmark, suppose we achieve a PSA level of less than 0.2, possibly this indicates that we have possibly given him good deep molecular response and he would have good long-term prognosis. So far, the patient is doing fine and no issues as of now. So this is what I was telling. Undetectable PSA at 6 months have showing improvement in overall survival. This is the second case. He is another 69-year-old male, non-diabetic, non-smoker. He has a history of coronary artery disease, inferior wall MI. He has underwent PCI to LCX and LAD twice, 2017 and 2020. He presented to us in February 2026, approximately 4 months back. Severe low backache radiating to the right leg and shortness of breath. NIHA class 2. ECG shows Q wave inversion. 2D echo shows moderate LV dysfunction and troponin elevated. So he was admitted under cardiology team, unstable angina and chronic ischemic cardiomyopathy. The low backache was marked as under evaluation. So in hospital, he worsened neurologically. He had sudden onset altered sensorium and speech and behavioral abnormalities. So we found multi areas of lacunar acute infarcts. So multifocal nature of infarcts across different vascular territory. Possibly he had an embolic phenomena and it is not suggestive of any localized atherosclerotic disease. So multifocal ischemic, we did an ultrasound. It showed multiple splenic infarcts, right kidney, possible renal infarcts. He had hyponatremia, acute ischemic hepatitis, and this one. Simultaneous infarction of the brain, spleen, kidney. So are we seeing something, a hypercoagulable state, or something in the heart that is shedding? So these were the two things we have seen. We did a TEE that is normal. So in this scenario, we did not see any vegetation. There were all cultures sterile. So we are possibly dealing with a case of hypercoagulability, malignancy associated. We did further evaluation. PSA is markedly elevated and he was started on relugolix and darolutamide. High lesions he had in this scenario also. So we had a similar case of literature where presented with hypercoagulability and radiculopathy. In this patient, the initial presenting PSA was 4795. In this patient, compared to the first patient, the additional challenge we faced is we want to give anticoagulation also because multifocal nature of the infarcts. So we need to add even newer oral anticoagulant. So we check the interactions and then started. Follow-up showed 1600 PS 241 and now 77. So this is in 4 months. I'm hoping in 2 months he would be achieving that level of PSA of 0.2, where it will give us a thing of functional cure. So this is what I feel unmasking Trousseau syndrome with an embolic phenomena in a case of metastatic hormone-sensitive prostate cancer as an index presentation. So this is what I want to share my experience of 2 cases. Open for inputs from anyone. Any doubts, I'm here to clarify.
Thank you, Dr. Santesh. Excellent presentation as always. So I see you using different AI tools for each this thing. I see a little notebook, little. There's no Claude in that because we just had a session on Claude. It's more, it's not very jazzy. Claude is very serious about things. Okay. So anyway, excellent. So anyway, we have a small discussion, scheduled. So I think Dr. Rakesh is here as well for your comments. So I think the first case, this thing, what have I seen 36,000? Absolutely not. I've not seen that high. Probably closer to 10,000 is the highest which I've seen. But the sky's the limit with PSA. The only thing which was surprising was I think the Gleason score was 3+4, so it's a grade group 2. So a grade group 2 behaving in that way, I think that is something which 36,000 PSA, kind of strange, which is that this kind of high volume disease, I wouldn't have expected this much. And the NGS was done from, means it was the biopsy which was sent for the okay.
Yes.
Well, because this AXL as a mutation in our liquid biopsies, we get it quite commonly, and we call them as chip mutations there because not very significant. But in the biopsy, getting an ASXL is something which I've not, encountered. But probably that's, as you said, that's why the aggressiveness was there, and excellent response as well as with darolutamide. So side effect wise, did you have anything like fatigue or
No,
it's
sir.
ADT side effects with
Uh,
relugolix?
Once the symptom burden improved, so they in fact felt better. So they did
Okay,
not notice any
right.
fatigue because there were so much overburdened with symptoms. So
Okay.
once they found improvement, so they did not notice any fatigue and all. Luckily, both the patient did not have any fatigue and all.
Okay. And in practice, you use relugolix quite commonly over
Yes. Sir,
dagerelix?
give an option to the patient, one-time option of this one. In the second scenario, I did not have a chance, sir, because posting him for even orchidectomy, I had to start anticoagulation early as possible.
Okay. No,
So
I mean, about oral versus, I mean, subcutaneous,
the scenario having the
ADT.
cardiac comorbidities, we need to have antagonists.
Yes.
So basically, I discussed with the patient, so they were comfortable tablets. 80%
Okay.
of the patients are on relugolix, or 20% would be on the injectable form.
Okay. For in my practice, it's actually the opposite. When I say tablet, they're like, I'm eating enough tablets already. Just give me an injection, so I've had very few patients, accept the oral, this one. So with the cardiac comorbidities, we use an antagonist. It's mostly dagerelix that comes down to the picture. So Dr. Rakesh is still with us?
Sir, sorry, sir. Like Dr. Rakesh sir has some emergency, so sir has
Okay. Okay. Let's see. So in your practice, do you use darolutamide? That means how often? Like many cases
Sir,
or
I suggest to a lot of my patients, I would discuss the data with them. Maybe around
okay.
15 to 20% would be able to take darolutamide. 80%, I would not be able to give because of a lot of things in real world, the finances, logistics, and lot of things would come. But I would discuss that this being a good option, especially if they are on polypharmacy and all this.
Okay. And with the Ereson's data, have you used darolutamide in the upfront setting?
Yes, in one patient.
And what? Okay. And the toxicity tolerance was
Very
it's
good, sir.
yeah.
I did not face any new toxicity and all.
So I think even for us, yeah, we had a doctor who is not my patient, one of my colleagues' patients, yeah, who's been taking it since long and absolutely no side effect. And I feel if the option was there to choose between Peace One and Erescence, what would be your choice in high volume disease?
Well,
With
ultimately,
finances, not an issue.
I would love to give RSN, sir.
Yeah. I think overall that's the general thing. I think the only issue is, yeah, the finance part comes in a way, but in practice, I think the what we prefer would be the Erescence, toxicity, polypharmacy, everything. And have you used triplet in low volume disease?
No, sir. No, sir.
Okay. Same here. So I think Dr. Rakesh was telling that it's effective in low volume disease as well, but I think that OS is not mature and most of the data is against, even docetaxel alone in low volume is a questionable benefit. So a triplet in low volume probably would be overkill. And
Now
this
I
is the
think
thing.
with the current ASCO, especially those who are having HRR or at least BRCA2,
Yeah,
possibly
Telapro.
non-oral triplet would be the thing. Relugolix is possibly this one
I'll
telazopam
throw
kind
in.
of.
So yeah, probably. I think of this, the TelaPro 3 has got quite some data in ASCO. So first line. So yeah, check everyone for your HRR in the first line itself is the go ahead in this. And they say that probably docetaxel may not work so well with the BRCA2 mutated. You can
Yes,
switch to just these two.
yes,
Okay. So I think, yeah, we've more or less covered it. The drug is awesome. The evidence is there. Uh, yeah, and we need to be counseling more of our patients, and most of them are going to be on polypharmacy. This age, there's nobody without diabetes or hypertension or something. And the second case was quite interesting. Yeah. So with the this anticoagulation, what was given? Apixaban based, or was it something else?
Piroxaban.
Rivaroxaban oral. Okay. So with the drug interaction, did you see whether it had some problem
Yes,
with
there is
Yeah.
some small drug interaction.
Okay.
We carefully monitored. So now he's having no issues. All the what do you say, the pain because of the ischemic lesions in the spleen and kidney, he luckily recovered. Creatinine stabilized, electrolytes improved, functional status is good. He's able to manage finances also.
Okay. So I think, yeah, we've kind of completed what we've set out to do. So thank you again, Dr. Santosh. If there's any questions from the audience can be taken. Otherwise, I'll hand it over back to Dr. Vinod. I hope we've, educated people on the where darolutamide stands in our current setting. So in India, I think as of now, we have approval for the Erescence, which is first-line triplet therapy, and for non-metastatic castrate-resistant prostate cancer, which I feel is a group which is quite small. Probably first-line approval, in patients who are low volume, who are unfit. I think darolutamide plus ADT would also be there. So thank you, Dr. Santosh, and I'll hand it over to Vinod.
Thanks a lot, sir. Sir, I would like to have a feedback from you, sir. Actually, Bayer has planned for a special program for CGHS and ECHS patients, sir. So ECHS patient. So as we have ECHS in Astra MIMS, so just want to take a small feedback, sir. Has planned for a NGS blood biopsy, liquid biopsy, for the patients
Okay.
CGHS and ECHS patients who have been covered in ECHS. So the patient,
Okay.
once the patient is been approved for Nubeca and started taking Nubeca, maybe 2-3 months, the patient will be automatically eligible for these tests, sir. NGS liquid biopsy test will be done
Okay.
through MedGenome, sir. So
Okay.
will this be helpful for the patients, sir? Like what will be your feedback on this, sir?
So the thing with the only issue with there is, I think, as Dr. Santosh he's said, means in the beginning, if you're looking at HRR, you don't look at it in a liquid biopsy. You look at it in the tissue. If you're
Yes.
looking for germline mutations, you can look for it in the blood. So in prostate cancer, with the approvals, you have it in HRR high. And for HRR, you need tissue. So I think if the approval is for either liquid or tissue, I think that would make more sense. Because in practice, most of us would want to send the tissue first. The liquid would be later. So that would be my feedback, because as per the guidelines, sending for the tissue NGS is what's mentioned, because you cannot get an HRR in the, in the blood per se.
Okay, sir. All right, sir. Sir, even if it is for NGS liquid biopsy, so the patient will be sent for this test maybe after progression, right, sir? Like,
Okay. No, as per the guideline, a metastatic prostate cancer, it's best to do it upfront. Now the guideline, and as we have new data in the upfront setting also, you have the new trials where, talazoparib along with combination of, I think talazoparib and which was it, one of them, enzalutamide or darolutamide, enzalutamide is approved. You have olaparib plus abiraterone, which has also shown good data. So I think if we could send it upfront is the best time so that you can plan later. In some cases, you can give, if it's a mutation is there and germline or something is there, you can then give as maintenance olaparib down the lane as well.
okay, sir. Okay. So thanks for the feedback, sir. So we
Okay.
have planned for the program, sir. So once the patient is, so your feedback is very valuable, sir. So I'll communicate with the company person also. So what are the good thing that we can do for the patient? We'll do it, sir.
Okay, excellent.
Thank you, sir. Thank you. So we are in the final stage of the meeting, sir. So I would like to thank all the doctors who has joined the meeting, and a special thanks to the speakers, eminent speakers, Dr. Rakesh MP sir, who has talked on the Arason's trial, Dr. Arun Chandrasekhan sir, who has talked on Aronaut study, and Dr. Santosh Kumar sir, the case presentation. So would like to convey once more, like from Bayer side, sir, very thank you. Thanks for the valuable time, sir, and a good discussion was also there, sir. So thank you. So
Thank you.
good night, sir. Good night.
Okay, good night. Thank you,
And
Dr.
Arun sir, good
Santosh
night.
and Dr.
Thank you,
Rakesh.
sir. Good
Yeah.
night, sir.
Good night.
So tech team.
Yes, sir. Can we end the session?
Oh, we can close the meeting.
Okay.